Okay, so keeping the ball rolling, our next plenary session, we have joining us Ontario Health, or representatives from Ontario Health. It's entitled An Update on the Implementation of the Quality Standards for Sickle Cell Disease. I have the fortunate privilege of introducing the moderator for this session. Fun fact, Gracia Mabaya and I actually did our master's together at Western University. So that is testable material, so it will be on the quiz. So I won't repeat it again, just so make sure you all heard that clearly. Gracia is a health policy and management professional committed to advancing healthcare quality standards. She holds an MSc and a Master of Public Health from Western, and is currently pursuing a PhD in health policy and management at the DeGroote School of Business at McMaster University. Round of applause for that. That's a big time move. She currently serves as manager at Ontario Health's Clinical and Quality Standards Program, and she plays a key role in shaping healthcare improvements across the province. With over nearly a decade worth of experience, she's played a pivotal role in development and refinement of numerous quality standards, notably co-leading the creation of the Sickle Cell Disease Quality Standard. Her work has been instrumental in driving improvements in clinical practices, advancing evidence-based care, and enhancing patient experience and outcomes across Ontario. So without further ado, if you can join me in a warm welcome of Ms. Gracia Mabaya.
Thank you so much, Mr. Delaney. Really appreciate the great introduction, and it's a pleasure to be able to moderate this session, as this quality standard is really close to my heart. It's nice to have seen it being developed and now into the implementation phase. So we have three amazing speakers in this session. So I will introduce them briefly, but please refer to the booklet or on the website for a full bio of each speaker. So first we have Ms. Lanre Tunjiajai, who is a global advocate for sickle cell disease, co-founder of several major organizations, including SCAGO and CDAC. Her work has advanced newborn screening, funding, and health policy, earning her multiple leadership awards. And after Mr. Lanre, we'll have Dr. Jennifer Bryan, who I have the pleasure of working with at Ontario Health. She's the Ontario Health's clinical lead for sickle cell disease and an emergency physician at UHN. Dr. Jennifer Bryan leads national equity initiatives and chairs a working group recognized for improving timely pain relief within emergency department care for people with sickle cell disease. And then we have Dr. Lance Archer, who holds a PhD in clinical psychology and works in supervised practice, providing care to children, adolescents, and adults for various mental health conditions, including mood disorders, anxiety disorders, trauma and stressor-related disorders, and chronic pain. Living with sickle cell disease, he actively advocates for patient care through leadership roles within SCAGO. So I will call forward Ms. Lanre.
Thank you.
If all the speakers could please come up.
So I don't have slide for this, and I think what I will talk about is a little bit of history. As Professor Adekele said, we have to know where we are coming from to know how we got to where we got to. So I wanted to say that from SCAGO's perspective, when it comes to quality standards for sickle cell disease, for us, the journey started many years before it was actually, developed. So for us, from our patients, our peers, reporting and providing feedback about the quality of care they are receiving in the healthcare system, notably, patients would say that it's the quality depends on the healthcare provider that sees them. They will go into an hospital this time and they will get amazing service, and they will go again and it will be very poor. Someone has called me at 1 a.m. and told me I've been rolling on the floor of an emergency room for 10 hours. Rather than take care of me, they are threatening to call security to kick me out. Why? Because they thought he's taking drug, he's faking pain, and so on. So this is the experience of many patients living with sickle cell disease. This made us to keep on knocking on the door of the Ministry of Health to say something needs to be done. Prior to 2017, elected officials in Ontario were sympathetic but nothing much was done, except in 2006, sickle cell was included in the newborn screening program. And in 2013, McGuinty, then former Premier of Ontario during his time, we were able to get some funding for UHN with Thalassemia Foundation. There's Riyad El Bird in the room. Riyad, can you indicate? He is the former president of Thalassemia Foundation of Canada. We did that advocacy work together, and we were able to secure some funding for UHN. But apart from that, nothing much was done when it comes to sickle cell disease. You wonder, when you consider similar autosomal disorders like cystic fibrosis, hemophilia, funding trajectory, research trajectory, so much gap, even though sickle cell disease has more population than these other disorders. So that was very frustrating for our community, and we keep, meeting with the ministry to say what needs to be done. I remember vividly between 2016 and 2018, met with the ministry, and then they said, okay, maybe we need to have what they call quality-based procedure, QBP, developed for sickle cell, which would be through the PCMCH, right? Developed for sickle cell, because PCMCH has developed 10 other QBP, handbooks, right, or standards. And then they came back and they said, well, yeah, PCMCH did not recommend that for sickle cell disease. So we said, well, notwithstanding that's already clinical handbook for sickle cell management for vaso-occlusive crisis, right, why don't you just use that anyways, right? We don't need to have new things developed. Let's use what we already have. So we recommended that, and they said yes, they will bring that back to PCMCH and to see what happens there. And they also mentioned that they would let them know to work with Sickle as expert in this area, and they introduced us to the ER lean, the then leans, leads and so on. So we were working closely, on this. I wanted to mention that those were going on, but not fast enough. Now, COVID-19 happened. In the COVID-19 era, the death of George Floyd and some others, and the Black Lives Matter movement helped to really highlight the inequities around Black health. People who identify as Black, what they have to go through and all of that. And so we used that, we capitalized on that, and intensified our advocacy with the ministry to say, people with sickle cell disease, their lives matter. Right now, it doesn't seem like it matters, because there is no quality care, they are branded, and when you see a 16-year-old say, I don't want to live anymore, I'm tired, it breaks your heart. Because you said, what took you to that space where you felt that way? And then when they say, when I even go to the hospital, where I'm expecting for them to understand me, they don't. They're branding me as drug seeking. And it's funny because in Ontario and many parts of the world, we noticed pediatric care is amazing. But when it comes to adult care, that's where you have the most gap. A child who's 17 years and 364 days will still get good care at Sickles. Had one more day, become 18-year-old, you're an adult, you go to adult hospital. At Sickles, they're saying, how is your pain level? What can I do to make it better? When you go to adult hospital, are you really in pain? Is it that bad? Are you really? So it's just different treatment, and people are tired. So that fueled our advocacy to say, we deserve to have good quality care when we go into our hospitals. And so we were happy that the ministry listened. And then there's a Black Health Summit table, which Sickle was part of. We were able to also help Ontario Health to recognize who to be on the quality standard working group and so on and so forth. We did all of this work to ensure that, the Black Health Plan is going to be strong, and we're going to have quality standards that will really drive change in this province. Because again, like I said earlier, we have documents before. We want something that will really make a difference now. So with the quality standard, we are very happy we are placed, with this. And I can tell you with the advocacy, with the work we did, supporting the quality standard and other programs through the Ministry of Health, we were also able to help secure funding for many centers across Ontario. Because this is part of our mission. We believe that patients should be able to receive care closer to home. Why do you live in Thunder Bay and you have to come to Toronto to get care? Why do you live in Barrie and you have to go to TGH for care or Sickle for care? You should be able to get care closer to home. And when you are in the hospital system, whether in the ER or you are on admission, surgery, wherever you are, those who are treating you should have good knowledge of your, of your care. So what we did also from our end to support Ministry of Health, Ontario Health, and their great work around the quality standard, we also put together models for healthcare providers to take to improve their knowledge, because we also believe part of the branding and is also due to lack of knowledge of the clinicians who might be seeing the patient sometimes. So we did all of this work to really drive and ensure that this happen, that good quality care are provided to patients. Now, implementation. So quality standard established 2023, great work, that's good. How do we hold accountable the healthcare professionals to make sure that they are using this quality standard and so on? So we continue meeting with the Ontario Health, with the Ministry of Health to say, how do we get this to happen? And so I know there are a lot of things that they've put in place, which I know Dr. Bryan will be talking about, to ensure that the implementation was successful. And even though I'm going to still say, till today, is still who you meet in our hospitals. But we believe care has improved, even though there are those instances that if a patient is not meeting the right person that fully understand, they will not get quality care. But overall, we've seen improvement in the quality of care that patients do get. So that's where I'll stop. Thank you.
All right, it is not fair at all that I am following Ms. Lanray on the podium, but I am very grateful to be here, to have the chance to speak with you today about what's been happening at Ontario Health. And Gracie, I'm hoping you might be able to help me. If I press the thing? Yes. Hey, okay, all right. Now we're rolling, okay. Gracie introduced me a little earlier. I've had the chance to meet many of you in the room already. For those of you I don't know yet, I hope we get the chance to connect today and tomorrow at the summit. I am an emerge doc at UHN, and since December of last year, I've had the privilege of being the clinical lead for sickle cell disease with Ontario Health. And that has given me the opportunity to better understand what's happening across the province with sickle cell disease and to try to continue to advance care at that level. My conflicts of interest, I have received speaking honoraria from a number of not-for-profit organizations, and as mentioned, I do have the role as clinical lead for sickle cell disease with Ontario Health. The objectives for my part this morning are to review a little bit about the sickle cell disease quality standard alluded to by Ms. Lanray just a few moments ago, to provide an update on implementation. So are things happening? What's happening that you may know about already or that you might learn about today? And to outline a process for developing a provincial model of care. So the quality standard is part of the Black Health Plan for Ontario. And the Ontario Black Health Plan is a strategy developed by community members, health leaders, and academics in response to long-standing health inequities experienced by the Black population. The Quality Standard Advisory Committee mentioned earlier included folks with a number of areas of expertise to bring to the table. Most importantly, folks with lived experience, including our co-lead, Serena Thompson, who is here today. Serena, if you want to hold your hand up. To my knowledge, I think this is the first time there's a lived experience advocate as part of a quality standard with Ontario Health. So that was an incredible step that Serena took with Ontario Health. And there's a little clap, I think a big clap for that. Yeah. The Sickle Cell Quality Standard includes 8 quality statements to really present the context for what high quality care should look like in sickle cell disease in Ontario. And you can see in the quality statements that starts right off with addressing racism and anti-Black racism. As mentioned in one of the questions for Dr. Adekile earlier, we know that sickle cell disease affects people of all races, but in Ontario, most of those affected are Black or otherwise racialized. So acknowledging the role of racism and anti-Black racism specifically in the gaps in care was very important in this quality standard. I'm going to talk about the implementation approach for the quality standard. And every step of the way, this has been done with community guidance. So with direct input from the public, from the advisory committee, from key informants and partners, and lived experience advocates. The 4 implementation priority areas are evidence synthesis, data monitoring and analysis, engagement with key partners, and application of implementation science and quality improvement methods. So you can see there's a real focus on data here. So using data to track how effective interventions are and to use data as an advocacy tool. There were 3 streams of funding introduced last year, thanks to advocacy, including in large part that done by SCAGO. The 3 streams of funding from the Ministry of Health and organized through Ontario Health included funding for dedicated sickle cell disease centers, pediatric recovery funding that mainly went to community health centers, CHCs, and quality standard implementation funding. And this last piece was really for short-term projects. So they were projects that could be done quickly within a few months to really support ongoing work in improving care. Some important milestones. So the quality standard was published in 2023, so now 2 years ago. There is an update to the e-report that was created to track metrics, and I'll talk a little bit about that in a moment. There is a province-wide community of practice. There is an implementation toolkit updated just this past February, an extensive education campaign across the province, and most recently, a needs assessment survey to inform a provincial model of care. So a little bit more about the dedicated center funding. You can see in the middle column there the established centers, and then on the right, newly funded centers or additional funding for special programs within established centers. So like Ms. Lonray mentioned, there is an opportunity for more people to seek care closer to home than there ever has been before in Ontario. The new centers are still in the process of getting established, but already people have been able to seek care close to home in Sudbury, in Windsor, and there's opportunities for that to continue to grow. A map just to show a little bit of the geographic distribution of the centers that exist. So in blue, the established centers, and in yellow, the new centers. I want to talk for a minute about the e-report. Hopefully many of you are already accessing the e-report. This is a source of really important data, and again, data is power, right? The e-report allows you to see numbers for your own hospital sites, as well as what's happening in the region and at the provincial level. There are a number of really important metrics that are available and being tracked there, including numbers of emergency department visits and hospital admissions, the time to physician initial assessment in emergency departments. That's all available there. So it's freely available through the One ID program. And in the past year, now community advocacy organizations, including SCAGO and SCAO, have access to this really important information. There is going to be some additions made to the e-report coming this fall that I'm very excited about. This is a sneak peek of some of the geographic information. So as you know, we don't have a province-wide registry for folks living with sickle cell disease. This is a step in between that, and allows us to see where in the province people live who are seeking acute care for complications related to sickle cell disease. So in the fall, this is some of the new information that you'll be able to access through the e-report. Right? It is exciting. It is deserving of a woohoo. Yeah. The implementation toolkit, and I've included the front page in English and in French as a reminder that all of the resources that are available related to sickle cell disease through Ontario Health are available both in French and in English. Yes. The implementation toolkit for every one of the quality statements that are part of the quality standard includes very specific change ideas and resources. So this is a very practical way of introducing change in your own setting for clinicians, and a great tool for advocacy again. The community of practice, I was speaking with some folks at my table about the community of practice earlier. I'm very excited about the community of practice. People have said, oh, it's too bad we don't have a way to share information across the province. It's too bad that I can't get access to an order set that's being used somewhere else and adapt it in my own setting. This is a way to do exactly that. So the community of practice, it is free. It only means that you sign up for the Quorum website, and there are almost 200 members now, so folks across the province all working together to try to improve sickle cell care. Through the community of practice, there are a series of webinars that will be starting again in the fall. There are drop-in sessions. There is a whole host of resources available. So it's really an important resource and a great way to ask questions of people who are working in similar spaces across the province and to share information in the way that we should be. The Evidence to Practice program, some people have heard about this, but I think this is something that's kind of been flying under the radar a little bit. Evidence to Practice is a tool that translates evidence-based standards into clinical decision support tools. It's available for primary care, it's available for acute care, and it's really a way of stepping up your site's implementation of the quality standard, using your own health information system. So at my site at UHN, we use Epic. Other sites might be using Meditech or Oracle. There are lots of options and support available. I want to give a shout out to the community partner-led education. That has been such an important part of implementation. Through SCAGO, the Sickle Cell Disease Education Program for Healthcare Professionals, crafted by Karen Fleming, who is over in this area somewhere. So yes. That has been an important resource for so many people, and again, freely available. Also, the Red Blood Cell Disorders Hub, which offers a 5-part holistic health series for free, that was created by Sindhu Shrikanthan, who is a social worker at the UHN Red Blood Cell Disorders Clinic. So 2 freely available, excellent sources of education. I want to talk briefly about the interconnected vision of sickle cell disease care in Ontario. So we've been talking about the things that are going well, which is very encouraging. There's a lot of good stuff happening, but there are still gaps. And one of the issues that has come up is around the supports available for established centers to be able to do the great work that we want them to do. So this is a quote from a leader of one of the established interprofessional centers, saying that they're receiving a lot of requests from other centers for support in setting up their teams and processes, and that the volume of requests has become somewhat overwhelming. And this is something that we were hearing again and again, that people really wanted to be supporting new centers, new projects, but that the established groups were really feeling overwhelmed, and in part because there was not a clear provincial model. People didn't know where to go to get the supports that they needed. So we're in the midst of a 5-step process to establish a provincial model. We are hovering around step 3 right now. So step 1 began with engaging key partners through the community of practice. Step 2 was a needs assessment survey to map current clinical pathways. You might think that that information is easily accessible to say, you know, who's being referred where and who's seeking care where, but that information has not actually been put together. So that's something that we've been doing. We are in the process right now of facilitating a series of group discussions on a provincial model of care. Many of you here have already been part of those discussions, so thank you. And those discussions will be continuing in the coming weeks. Using the information from the needs assessment survey and those group discussions, we are going to be meeting with an advisory group in September to collaboratively develop a draft framework for a regional and provincial model of care. That's going to continue to be revised over the coming months with an aim to have it ready for prime time in March of 2026. And so stay tuned. Please do connect with the community of practice so that you can stay up to date on the process as it continues. I'm going to do a very brief 2-minute, thank you, Gracia, summary of the needs assessment findings. So we had representatives from 45 different organizations across the province who participated. Lots of things that are working well, some of which were highlighted at the earlier talks today. So renewed focus and investment, use of clear metrics. The dedicated interprofessional sickle cell disease centers are offering great care. The available provincial tools, and of course the importance of early identification in order to facilitate early intervention and engagement and collaboration with community organizations. A lot that's not working yet. Right? And I say yet because that is part of the process. That's what we are working towards. I think most importantly, amongst all of this, is the fragmentation of care, that our care is disjointed across the province. If we had a better system of coming together, we would avoid things like duplicating efforts and underuse of existing expertise. what we are working towards, it may look something like the hub and spoke model that Dr. Adekile mentioned in his talk earlier this morning. This is the model that's most well known in the literature. It's the model that was included in the 2017 clinical handbook for vaso-occlusive crises, and it includes a role for regional centers of excellence as well as satellite centers. The next steps for us are we're continuing the virtual meetings with key partners. The advisory group has been coming together over the past few months with representatives from the established dedicated centers, from the new dedicated centers, from lived experience advocates, with representation from community advocates and other key partners across the province. Once the draft model is put together, that's going to be shared widely, and I would encourage you to please give us feedback on that. What are the things that we're missing? What are the pieces that you know about that should be included that may not be yet? And if you do have additional feedback, there's an email address there, so qualitystandards@ontariohealth.ca. And I'm going to wrap up there. Thank you so much for your attention and your engagement, and I'm very much looking forward to Dr. Archer's talk, who's coming up right now.
Good morning, everyone. Thank you, Dr. Brian, for just going over aspects of the Ontario Health Quality Standard. I want to first open with my disclosure of conflict of interest. I am a member of Novo Nordisk Patient Advisory Council, and I'm also a member of Sickle's Board of Directors and also their co-chair of the Patient Advisory and Advocacy Council. And today I will be speaking briefly on patient feedback on the Ontario Health Sickle Cell Disease Quality Standards. I'd like to start with what we know. So, we know that sickle cell disease is a debilitating condition marked by vaso-occlusive crises that often require presenting to the emergency room to be resolved. We know that the recommended treatment approach is interdisciplinary in nature, meaning that there is a combination of non-pharmacological intervention, but mostly pharmacological intervention, including opioid therapy. In fact, the National Health, Lung and Blood Institute recommends aggressive opioid therapy for treatment of acute vaso-occlusive induced pain. Unfortunately, though, clinicians are more likely to be wary of opioid addiction in sickle cell disease than in other chronic pain conditions. We also know that significant delay in receiving pain management often leads to health issues and even longer hospital stays. Research suggests that longer time to administration of opioids and intravenous fluids correlated with longer length of hospital stays. And in Ontario, it is believed that optimal care has been thwarted by opioid phobia and discriminatory practices, including racism and anti-Black racism. And so, for this reason, the Ontario Health Quality Standards were developed to address gaps in providing high-quality care. And as I said earlier, I will be sharing with you what patients have been experiencing since this implementation. So starting off, in general, there has been a substantial appreciation within the community for the significant reduction in wait time at hospitals. This suggests that most hospitals are more mindful of and even adhering to the quality standard statement number 3, which speaks to vaso-occlusive crises. You see, for many patients, there has been a remarkable reduction in the time to pain assessment and treatment, although some find that this reduction is dependent on the physician or even the nurse who is working that shift. Nevertheless, what this has done for patients is it has allowed them to receive faster pain relief. And this is a good thing because we understand that rapid assessment and administration of pain meds decrease hospital stay. So this appreciation is likely to, this appreciation that patients have is because of the reduction in the length of time to receive treatment. And so this is good because it allows for them to have less disruption in their livelihoods. They're able to go home sooner, they're able to be with their families, and they're able to return to work. Another positive that has come out of the quality standard is that there has been greater attention to comprehensive assessment and even the provision of psychosocial support, which has been more favorable. And this suggests that we are now seeing a holistic approach being taken to managing sickle cell disease. And we know that with greater attention and even a broader outlook or approach to treatment, it creates opportunities for early intervention. So I want to say that what I appreciate about the quality standard is that there has been an increase in education. And I find that even through SCAGO's e-learning modules, so many physicians, healthcare providers have become more aware of treatment recommendations and how best to serve patients with sickle cell disease. That's great. Notwithstanding the good that has come out of it, there are still ongoing concerns. Specifically, there is low adherence to Quality Statement 1, which speaks to racism and anti-Black racism. Patients are finding that there is poor quality of care being given to them when they are admitted, despite having favorable ER experiences. So inpatient admission continues to be an area of concern for many patients. And generally speaking, patients are describing their experience as medical dehumanization. I want to share with you some of the comments that patients have shared with me, result of, just by virtue of conversations that I've had with patients. Many are saying that they don't listen to us. You are getting messages related to, you can't be in so much pain. Why are you here and not referring to another hospital? You're here again? You were just here. Some patients say that they hear, oh, you're still here, you should have been gone by now. And so they experience this as PTSD all over again. Some other reaction is that there's no substantial change. Things remain the same, still a lot of stigma. I'm not hopeful they'll ever change. They don't communicate. Huge empathy gaps. Some are saying that I have zero faith in the healthcare system at this point. One patient shared with me, there's no patient-centered care. It can't be that every single doctor has the same approach. You see, the quality standard itself highlights that negative outcomes can be expected when racism, that includes labeling, devaluation, and even just a social disqualification of the person, whenever these things are present, we can expect negative outcomes. The statement, quality statement 1 of the standard says that to improve health outcomes, the care that patients receive should be free of provider prejudice and bias and should address their mistrust in the healthcare system. But to date, some patients are reporting that has not been their experience. The statement even mentions that they should be given opportunity to be as healthy as possible. Still not experienced. Furthermore, it says patients should be able to get high quality health care when they need it, no matter where they seek that care. Some patients are still not experiencing that. And the quality standard says clinicians should ensure they are equipped with the knowledge skills to provide culturally competent care and even anti-oppressive approach to treatment. For some patients, this is still not experienced. And so in general, this means that there are many hospitals still not abiding by the standards that have been, outlined to address the needs of patients with sickle cell disease. Medical dehumanization manifests itself when they are reporting that they are feeling unheard, unseen, unsupported, and uninvolved in the treatment planning process, even though the quality standard clearly states that they are to be included in it. The standard says that the severity of pain must guide pain management. But for many patients, they are reporting that they are not regarded as the expert on their condition, which is clearly outlined in Quality Statement 3. And so patients are finding that they are just being disregarded despite the fact that Quality Statement 4 says that people who present to the ER with life-threatening condition, they should be, the severity should be identified, they should experience clinical assessment, and that should be managed by individual treatment plan. Patients are saying that they are not always experiencing this because they're often judged based on their physical appearance still. And so this is quite problematic because it's suggesting that despite having the standards for how treatment ought to be, there are comments that patients are receiving that expose prejudices, including commenting on how they are expressing pain. Some patients find that they are not 100% believed when they are describing their pain. And what's interesting about this is one patient shared with me that because of her early upbringing with her family back home, the way that she expressed pain, she was often ridiculed for it. And so over time, she has learned to become very stoic. And because she is very stoic, reserved, there is a disbelief that her pain is at a severe level. So the standard clearly asks that we just be mindful of administering thorough clinical assessment, but not based on initial impressions of people's physical appearance. Yet patients are reporting that that continues to be their experience. You see, another harsh reality is that patients with sickle cell disease can often experience refractory pain that unfortunately perpetuate long hospital stays. So the quality standard does not explicitly explain what high quality care should look like during hospital stays, even though it does speak to the fact that severity must be identified, the condition must be managed appropriately with an individual plan. Still, patients are reporting that even though the quality standard suggests referring to specialized centers and experts while they are admitted in the hospital, the treatment they receive feels inhumane. Quality Statement 3 stipulates that throughout a vaso-occlusive acute pain episode, we are to regard the person as an expert on their condition, acknowledge their pain, listen to what they say, and respect their views. But still, patients are reporting that this is not their experience. And so given the experience of patients with refractory pain and even long hospital stays, patients want the quality standard to extend to what treatment ought to look like within the hospital setting, in inpatient admission. They want clinicians to demonstrate a commitment to medical humanization, which has to do with respecting their dignity, their individuality, their biopsychosocial and spiritual dimensions, to have empathy, humanity, and even respect their involvement and watch out for the way that they communicate. They are demanding greater accountability for the way patients are treated. The standard itself notes that organizations and health services planners are to ensure healthcare providers in the ER as well as in other units of the hospital receive sufficient education and training to provide high quality care for people with sickle cell disease. And so this education should include appropriate understanding of their lived experience and to just be mindful of the guidelines that have been set for managing sickle cell disease pain. Patients are asking that healthcare providers resolve their opioid phobia, meaning to work through their fears of prescribing by seeking to educate themselves about the nature of sickle cell pain and to abide by the established guidelines, to become familiar with established guidelines for managing acute and chronic pain in sickle cell disease. Again, going back to what research suggests that even according to the American Society of Hematology guideline, we understand that there has to be those patients who receive opioid therapy and it has been found to be effective, that there needs to be consideration of the baseline and prior effective treatment for when they present to the hospital. It's important that they are incorporating the patient's preferences into shared decision-making process, even though it's expected that they are to educate patients on the limitations and the harm of opioid therapy. Still, research suggests that earlier titration of opioids to an optimal analgesic dose during inpatient admissions can reduce hospital length stays. So these are the requests that patients have moving forward. It really boils down to they want to experience better care that speaks to their humanity, their dignity. It is unjust that because of provider biases and negative beliefs that patients have to suffer even more because of their own individual, of healthcare providers' own perception of pain. It's unfair. And so, as I about to take my seat, I want to thank you for listening to me and listening to the voice of the patients in Ontario with respect to the quality standards. Thank you.
Thank you so much to all our speakers. Just want to look across the room to see if there are any questions. There are a couple in the back.
Good afternoon. I have a question for the panel, and I'll wait a moment. Just want to make sure you can listen, right? I don't say it twice. Good afternoon to you all. My question for you is, we heard about the quality-based procedures not being funded from a sickle cell perspective, but it gets funded from, other conditions like jaundice. You guys know it's the passion, right? That I'm just so excited to be here. So it's jaundice, for example, that might get funded. What I'm interested in, we have the standards. 2023, it's been 2 years. why didn't we tie accountability to it, right? Because we've implemented it, but there's no reason anyone must follow it. And we know that for hospitals to move things forward, you must tie accountability to it and not leave it for, thank you, not leave it for each individual center to have different passionate people who will help move things forward and make certain areas accountable. Why is it just not accountable? So maybe the provincial model might lend to that a bit, but I'd like to know, Ontario Health, what are they kind of looking at really leveraging their position to make it accountability? You won't get funding if you don't make sure patients get their meds on time. If you have too many patients come back as readmissions, there's things to tie it to, so I'm interested where we're going with that. Thank you.
Thank you, Karen. I wanted to thank you for that question. It's something that I have been talking to ministry for a long time. Accountability is very important because for us at Sickle, I'm going to say, for instance, why did we even establish the online models, which some of you here helped to put together, as well as clinicians? It's because of the reported suboptimal care that patients are experiencing. When we then advocated for resources with the ministry, we're saying, when you give all this money out to these centers, how are you going to ensure that these centers, these hospitals, these clinicians are providing the quality care for the patient? It's very important because up till last week, I'm still getting reports about I was in this hospital and I'm not getting good care. So ministry is spending money, they're doing their part, and we're grateful. But how is the ministry going to ensure accountability? I've talked about this over and over, and I've said, let's use money as the weapon. If patients are reporting poor care, cut the funding from that center. When the funding is cut, the people will smarten up and they will start to provide the right care at the right time. But if there is no one that is monitoring that, I know there must be some monitoring evaluation process, and ministry have said that to us, but we need to make sure that money is also used as a weapon to ensure that patients here in Ontario get the right care at the right time. So we've asked the ministry to do the ombudsman line or something like that. They said they can't do that. What Sickle is now doing is we are now working on a patient report portal whereby patients would then provide their feedback on the portal, and we can then start to collect what their experiences has been, what is going on, and so on and so forth, because I'm sorry, we have to hold our clinicians accountable. Ministries listening, they're spending money, but the healthcare providers have to do their part. Thank you. And I'll let Dr. Brian follow up on that.
Again, I get to follow Ms. Lundgren. No. So Karen, absolutely. I think a little bit of historical context, maybe taking a note from Dr. Adekile this morning. So the 2017 clinical handbook for vaso-occlusive crises, a wealth of important information, a ton of work from all of the people who participated in putting that together, no funding for implementation, and so it sat on a website. Right. The next step for that is the quality standard and having money tied to implementation. Right. But you're absolutely right. The next step after that is having something tied to accountability. Each of the hospitals in Ontario have a responsibility to identify quality improvement metrics that they agree to be accountable for. There is a quality improvement metric linked to sickle cell disease, but it is still one of the optional metrics. So it is not a required metric. And that certainly is what's needed, right? Part of the way that I think we've been trying to introduce as much accountability as possible without having access to dedicated funding for accountability is by sharing information. So the e-report, being able to see how are different hospitals comparing to each other in terms of the time it takes for initial physician assessment and other key metrics. Having that information widely available is not the end-all be-all for accountability, certainly, but I think having that information available publicly is very helpful so that it's very obvious which centers are starting to work towards the quality standard and which are not. So that's one step in the right direction. But I think that that's an excellent question. The other piece that I'll add in just before I wrap up is the importance of SCAGO and keeping us all accountable as well. So having regular meetings between community advocacy organizations, and most particularly SCAGO and healthcare centers. So with UHN, it's a meeting every 6 months? Yeah. So every 6 months, where the key players at UHN sit down with Lanray and other representatives from SCAGO to answer for what have we been doing in the past 6 months. And that responsibility for accountability should not lie with SCAGO, even though SCAGO is doing such an amazing job in that way. But these are all things kind of coming together to hopefully move the needle. But again, thank you for an excellent question.
I think good afternoon. Thank you very much for that presentation. I just want to make, I'm here, I'm very short. I just want to make a comment more than anything. I just want to encourage the SCAGO and all the organizations that are involved in this care of people with sickle cell and inherited blood disorders. I had some family members who suffer from this. I'm going to talk about what I know for sure. I work in emergency department. Over 18 years ago, we don't have what we have now. I have my clinical practice leader here teaching us or giving us the insight into what is expected, the standard of care. Emergency department can be upside down certain times that you are competing with people with MIs and so on, but sickle cell is actually categorized higher in that category, so that we have the standard of care that we have to follow as a professional. You can't be challenged at any time. Why didn't you follow this? Why didn't you follow that? And there are certain things I didn't know myself that, I became aware with the training. Because somebody may have sickle cell disease and they may have been given some medication, they're sleeping, and the young nurse said, "Oh, I just saw her sleeping. Why is she asking?" Well, if she's due for new medication or the medication that she's supposed to have, give it to her. She's entitled to it. So these are the little knowledge that we didn't have so many years back. So I just want to encourage you with what you're doing, because one of those reasons why I'm here today, I want to see how did they come with the provincial government, put it into policy and procedure for us to follow. Now, within 5 hours, I can see why. Keep on doing what you're doing. God bless you.
Yes, please go ahead.
Hi. I wanted to ask, as you look at moving this forward and just drive home the importance of the inclusion of the anti-Black quality standard, the anti-Black racism quality standard, because as we moved our work forward, that was the crux of allowing us to include that in how we incorporated that into the delivery of care. And I will tell you that there's organizations that don't necessarily want that a part of that care because it's such a difficult topic to talk about, but so relevant and important. And so as you move forward, just including that, and hopefully you won't get pushed back given the environment and climate, but if you do, just know we'll go to bat with you, because I think it's such an important piece of the work and so needed, because we have clinicians that will say, just let's work on, quality standard 3 and let's get them pain medication in that certain time. And that is one part, and you're missing an entire kind of section of that humanistic approach. And so I just want to drill home that importance because it's such an important part of being able to give people care where they feel like they're seen. So thank you for including it because it helped us drive that work in our organization and helped open a lot of clinicians' eyes as to why that link exists. Because trust me, we faced it. We're like, why are you linking it? Why are you talking about anti-Black racism? Why does that have to do? I treat everybody the same. So thank you for including it.
Thank you so much, everyone. I don't know if there are any last questions. Maybe we'll take one more.
Thank you. I just wanted to follow up on the last point and ask how you would recommend that we approach anti-Black racism. I work in a healthcare center. There are many, many healthcare providers in inpatient units, in emergency rooms. How do we do that? It's not something you can measure as easily as time to opioids.
First of all, in the words of a patient, it says, check your biases at home, right? Healthcare providers must come to work with an open mind to treat patients that need care, whether they are Black or they are not Black. It doesn't matter the color of your skin. And we've seen situations whereby we find healthcare professionals, a patient reports, healthcare professionals are saying, yeah, we don't really like sickle cell patients in this unit. Would you say that to maybe cancer patients? Like, it's a lot of racism and stigma when it comes to this disease, right? And we've seen patients reporting that, clinicians are saying the first question they ask somebody who is in pain is, do you have opioid-related problems? Like, are you addicted to opioids? How do you ask somebody who said they're in excruciating pain? So there's a lot of training that clinicians still need to go through, and this is why, in my opinion, every clinician in this province should take the online model that SCAGO has created, because it will open your eyes. Even when you're taking those models, some of the videos are from people with lived experience. You can listen to them and you can hear what they're saying about their care. And there are many videos out there that many of our patients have done, even with media, mass media, about how they feel and the quality of the care. So anti-Black racism, I think, will start with education, ensuring that it's not optional for clinicians to take the models, to take the course, to know. And I think also having patients to come to training days in the hospitals and so on, listen to them will also help. But they must also check their biases at home. Empathy is a big part of it. How do you watch somebody roll on the floor for 10 hours and you are threatening security than saying, maybe a grown-up man rolling on the floor would not do that, something is not wrong. Why are we not looking at it from that end? Why are we looking at, this person is Black, they must be looking for drug, and that's why they're here? So I think training, they must also have the interest to want to do this. And lastly, I agree with the hub and spoke model in hospitals, but I also want to stress that spoke cannot be spoke forever. They gotta grow from being a spoke to also be an hub. Because if the patient must get quality care closer to home, the centers around them must be able to do much more than relying on another center for a lot of stuff. So we need to ensure that we empower our centers, and when we have quality programs in the centers, I also think the quality of care will continue to increase. And Dr. Bryan and her team at Ontario Health are also doing a lot of work to ensure that, there is data on what have been reported in the hospitals for them to see which centers needs more work or needs more help to address any of the 8 quality standards for sickle cell apacito. Maybe Lance, you have a comment?
Thank you. I think what I'd add to that, Ms. Flannery, is what just came to my mind is how when we see physical appearance, we formulate some judgment around that person. So you look at Lance and you probably think that he's educated, but then if I'm unkempt in my appearance, if I have my shirt out of my pants, if I have, I grow my hair, for example, and it's all unkempt, then you are probably likely to have a different perception of me. How do we address anti-Black racism is having respect for all. I think what I find is that our judgment gets in the way, our perception of people and how they look gets in the way of how we adequately attend to their needs. So addressing anti-Black racism and how we approach that start with respecting the individual regardless of how they present, whether they are unkempt in appearance, whether their speech is slurred, whether they are wailing and just being on the floor racked with pain, regardless of how they look. It boils down to that person is deserving of respect. That's my thought.
Can I just add one thing? I know that I think it's Humber College now for their nursing program has a mandatory annual session where they bring people with lived experience, and I understand that's been helpful. I also think that when we're starting these spokes, we should have people who are involved with sickle cell care be called when someone comes into the emergency room so that there's an ally or an advocate, because as I say, I work in emerge and inpatient units, and you can say we need to respect everybody, but that's a lot easier said sometimes, and having people model the way that they need to care for people might help. And I also was hoping maybe, I don't know whether there's some sentence or something that a family member or a patient could say that would just trigger someone to stop and think. I don't know. I think that's the biggest challenge that we face in healthcare.
If I could add in, for clinicians, I think it is particularly difficult often to talk about racism and racism in healthcare. Because we all go to work thinking we're doing a great thing. We're trying to help. Of course we can't be racist. Of course we can't be biased. And we have learned a lot of things very wrong over the years. And on learning that takes a lot of time and a lot of effort. And we don't know what we don't know. And so certainly you do hear folks say, oh, but I treat everybody the same, right? Or, oh, but I don't see color. Oh, but, all of these other things. And I think it's the voice of lived experience that shifts that. So hearing, just like what Dr. Archer talked about now in terms of how you're dressed, I heard that for the first time in 2017 when I asked a patient about their experience in the emergency department, prompted by a student who was interested in sickle cell disease. And this young man said to me, I had to dress up today to come in. Those are the stories that get people thinking about what they might have been missing, right? I always want to assume the best of people, right? I want to assume that my colleagues are coming to work wanting to do the best work possible with the tools that they have and the knowledge that they have. And when that's not happening, to me, that's a gap, right? It's a gap in knowledge. It's a gap in access to resources. I go there first before I say, oh, these are just bad people, right? Because I've certainly seen marked improvements in clinical care with education, with access to resources, letting people who want to do the right thing do the right thing. There have been over 900 healthcare workers across Ontario in the past year and a half who have participated in anti-racism training. There are some really excellent resources out there, including including through SCAGO, including through TASIN. A little, shout out back to the implementation toolkit. There are a number of resources there as well. But sometimes getting people to know that they need to do that training, it comes from hearing those stories of lived experience. When you talk about the training happening at Humber with the nurses, that's incredible, and it's a mandatory part of their program, and has been for a number of years. I know that, part of what I'm representing here is Ontario Health, but so much of what has happened that's good in sickle cell hasn't been something that's come top down from a big on high with the province. It has been from individual advocates coming together, and that program at Humber is an excellent example of exactly that.
Thank you so much. Such a powerful and insightful conversation. I know there were some hands still raised, and I'm mindful of time, so I'm wondering if folks can maybe approach the speakers during break time to continue the discussion on this really important topic, and really grateful to all of our speakers, particularly the lived experience perspective. I think that we, as an organization, Ontario Health and SCAGO as well, have a lot to take back in terms of thinking how to continue moving the needle towards the implementation of the quality standard, and also thinking about accountability as it was raised. So thank you so much. Please feel free to scan the QR code for the self-evaluation if you haven't done so, and I think I will give it over to the chair, or are we breaking?
Nope, perfect segue, just like we choreographed. Thank you. Can I have a warm round of applause for our great Simabai and our running speakers? Thank you so much.